Hello all, Evan Laguris here with Illinois Eye Center, here to show a tube exchange that I recently performed. This is a patient with uveitic glaucoma who's had a superior temporal Ahmed, which we're going to replace, and a inferior nasal Baravelt, and still with poor glaucoma control. Both tubes are well placed in the sulcus. What I've done before I've started this video is I've placed a paracentesis and filled the anterior chamber with Provisc so that we don't experience hypotony when we remove the tube from the eye. Right now I'm freeing up this patch graft from the underlying sclera. The patch graft actually was good enough to be reused, but they'd already opened a new one, so I decided to go ahead and use the new one. In these cases, I think cautery aggressively is a good step because we don't want to have any epithelial ingrowth. We want to minimize our chances of a second tube failing, and it helps, I think, remove any remaining tenons that you may not have gotten off. So now I'm just freeing up the conjunctiva from the underlying tenons and sclera. This is in 4 times speed. Obviously, my hands don't work this fast. What you'll notice is how posterior this tube is, and I wish I could blame it on someone else, but this is my own handiwork. And this tube was about 14 millimeters. The plate was about 14 millimeters from the limbus, which is obviously too far posterior. This patient has about a 25 millimeter eye, so I don't think this was compromising the optic nerve, but obviously with the tube this far posterior, you do worry about it touching the optic nerve. So right now we're just, again, trying to get freed up as far posterior as possible, trying to free everything up. I really want that conjunctiva totally free from the tenons so that we have greatest mobility when we pull it forward at the end. I'm just kind of changing my tension there. And then very soon here we're going to see that we're going to get into our capsule that's surrounding our Ahmed. What I found very interesting in this case, and I don't know why, maybe related to her underlying uveitis, is that her capsule around her Ahmed hadn't really grown in very much, and this tube has been in for over a year. The inferior nasal Baravelt's only been in for about 4 or 5 months, but this tube has been in for over a year. So I was expecting, especially with uveitis, to have a really socked in capsule, but as you can see as we open it up here, the Ahmed underneath is very easily seen, and that gush of fluid very likely is just from the capsule and not from the anterior chamber because we have the anterior chamber filled with Provisc. So I'm just basically dissecting, and as I'm dissecting, I'm noticing how freely this Ahmed is moving in the capsule. And so I thought, it'd be a pretty difficult removal, refreshing our anatomy on where the holes are on the Ahmed and refreshing our knowledge. But really, this thing is rotating out very easily. Only one of the eyelets posterior really had much of any tenons in it, and you're going to see how easily this comes out. This has not been my experience in most plate removals, but this one turned out to kind of give us a nice easy win. So once I get the Ahmed out, as you'll see here, what I'm going to do next is I'm going to remove most of that capsule because we don't want those cytokines that are in that capsule to go into our new tube. Dr. Mary Chow, and I apologize if I mispronounced her last name, recently showed a video showing using this material, this capsule material, this tenons material, to recover your new tube, which I thought was a really elegant way of doing this. But again, I already have a patch graft available, so I decided just to use what I have. Right now, I'm just trying to get rid of any underlying tenons that's still remaining, and then I'm going to be aggressive again with cautery because I really want my tissue free as possible. I don't want to leave anything behind that could give us a chance for aggressive fibrosis again, because this patient has a severe glaucoma and really needs really good pressure. So we're going to be really aggressive with cautery here, and you'll notice as I cauterized over my opening, my sclerotomy that I had made for the previous tube, and we'll see that shows up later. So now I'm just checking to see where the muscles are. I think we found them pretty well. I've already tied off my Baravelt with 7/0 Vicryl. We're going to slide that into place here, and that's done without difficulty. I don't use a ripcord, and I did actually check the distance here. This one's about 9 millimeters. Typically, I don't suture my plate to the sclera, but given that this is a reoperation, I did suture my plate down using 7/0 Vicryl times 2. And this is not a technique that I normally do. Normally, I just suture my tube, but I figured with a reop, best to give it as good a chance as possible. So I apologize if people have a better technique than this for suturing. This isn't a common step for me. But that's about 9.5 millimeters posterior from the limbus is what I measured. And we're just going to get that nice and flush. Okay, and I'm going to try to put this tube back in the sulcus again. This patient has had multiple very high pressures. I really don't want to damage the endothelium any further if we can avoid it. So I'm going to place my bevel posterior so it's away from the iris. First, I'm going to reinflate the sulcus. And then when I go to insert the tube, you're going to see I can't get the tube inserted because I've actually cauterized over my opening. So what I did is actually use my jeweler forceps to reopen just the very tip of that area once I realized, oh yeah, I've done that. So I just stick the jewelers right in there, got it open, and the tube slides in freely back into its original location, into the sulcus, and you can see the tip of it poking out there just under the iris there. I sutured this down using 8-0 Vicryl, and then I use that needle to create 6 to 7 fenestrations, which very often, can provide pressure relief. Sometimes they don't. Sometimes they work too well. This patient, after the procedure, she's about 4 weeks out now, has had pressures in the mid to low teens, where she started up in the 40s, actually. This is that new patch graft, and I actually usually glue my conjunctiva closed and then put some safety sutures. So this is Tecile tissue glue that we use to glue this closed, and you'll see how nice and pretty that looks. Looks like we didn't even do anything. And then I do put 2 safety stitches, 8-0 Vicryl wings, just in case this ends up, the glue ends up melting earlier than we would like. On the superior temporal part here, there's a little area I didn't like that was gaping just a bit, so I do put an extra 8-0 Vicryl right next to that original one just to be sure. And then once we get the conjunctiva all closed, we'll do our injections. This patient has had a pretty aggressive steroid response. I usually use subconjunctival Decadron, but I did not in this one. I give intracameral Ansef, and that's after I removed the Provisc from the anterior chamber using VSS, and we'll see that come out now. And like I said, this patient thus far has had a good outcome. We'll take wins where we can get it, especially in uveitic glaucoma. Please feel free to post any comments or any suggestions for future cases, and appreciate you watching my surgery. This is Evan Laguris with Illinois Eye Center. Thank you.